Good evening, everyone. Welcome to First Aid AMC MCQ, free 2-week sessions again. So this is your one of the last class of this free session. You have today there is one session and then there is another session on 27th, and that will be the end of your free sessions. And then we will start the course in the full rhythm. So today is not my class. I just came to introduce with you one of our other doctor who normally takes our most of the question solved classes. So let's welcome Dr. Aruz, and you'll notice that she is one of the most highly recommended mentor in our course at the moment for the MCQ solve classes. So I'm hopeful that you will enjoy the session. Again, these kind of sessions initially becomes quite tricky for everyone because you don't have much of an idea about the theory. And when you don't know the theory a lot, the questions can be a bit tricky for all of you, which is understandable. But try to try to understand that the purpose of this class is to solve questions, not to go through the details of the theory, because you can see that I discuss the theory in details. So don't go too much into the theory for these kind of classes. Leave the theory with me and do as much questions possible with Dr. Aruz in here. So that will be your idea as well. Okay. So I will not take much time. Dr. Aruz, you can take over. Thank you.
Thank you, sir. Hello, everyone. How's everybody? Okay, so I'm just sharing my screen. Can you guys see my screen? Okay, so let's get started. Okay, so like Dr. Arshan said, this is a random MCQ discussion class. So we'll be going through various MCQs, which will be obviously from different topics. Okay, for example, one would be from CVS, other would be from respiratory, other would be from pediatrics. So it would be like a very like brainstorming session for you guys. And it would seem a bit overwhelming, but as you will start preparing and read the theory and then try to solve the questions, it will be easier for you guys. But if my recommendation is that if you start preparing the MCQs, if you start solving the MCQs from the start of your preparation, then it's more beneficial. Okay, because you get the idea from the start that how the MCQ comes in AMC exam. Secondly, the second thing I want to say is that these are recalls. Okay, by recall, it means that some candidate who gave the exam, he came out of the examination room, examination hall, and then he tried to recall the questions. Okay, so these questions, they are never complete. There is always some important information missing in them that can lead to a diagnosis or answer or option. Okay, so most of the times you will see that more than two options you find that okay, this one is also correct, this one also seems correct. So that will happen. Okay, because the question is not complete. But the purpose of solving recalls is you get an idea that okay, this topic can come in this way. Okay, the only purpose of solving recalls is this. You do not have to remember or memorize the recalls, because the people who do this, they can't pass their exam. Okay, because these questions are incomplete and AMC never repeats the question. They just change the question in some, like they will maybe change the age, maybe they will change the, for example, if they ask what is the next most important investigation, to some candidate they will ask what is the most definitive investigation. Okay, so they will change a few wordings and then the whole answer will change. So you need to grab the concept from that recall and you'll be good to go for the exam. Some of you might have given the exam before, maybe second or third attempt. Some of you will be total beginners. Some of you will be in there somewhere between in between their preparation. So all these advices are for everybody, wherever you are in this stage, in any stage of your preparation. Try to solve the recalls as much as you can. Okay. So yeah. So basic. Wait. Okay, so I have attached the reference materials from where you can read. First of all, AMC handbook is very, very important. This is, at least you should go through this handbook at least twice. Okay, because it has a lot of MCQs and it tells you that how the questions come in exam. There are like 7 to 8 lined MCQs, clinical scenarios, okay, and AMC always gives clinical scenarios. Most of the questions are clinical, like almost 99%. Only one or two would be a very 1 or 2 line questions, but that is also rare, okay. So you need to prepare according to clinic. You have to adopt a clinical approach in order to solve the questions. So in order to get that idea, AMC handbook is you have to do it at least twice. Other some topics, like for general complaints like the patients who present to OPD, such complaints and diseases, RACGP is a very good website where you can find those topics. For example, if you want to study about pulmonary embolism, you just type on Google pulmonary embolism RACGP. Many articles will come, and then just choose the article that is the latest one and just read that. In the start, obviously you will feel some difficulty about how to read the topics, because many people, they don't get the idea that how to read a topic from the Google. But as you will practice and read, you will get to know that what information is important from such a big article. Okay, so the more you read, the more you will become efficient in that. For obs and gynae, we have Ranscog and SA Health. Similarly, same as RSCGP, you have to type on Google and information or the websites will come. RCH is for Pediatric, Royal Children Hospital. For psychiatry, there is RAN-CP, College of Psychiatry. It's not because the articles in this website are very, very, very detailed. Uh, it's good to read the major topics like schizophrenia, generalized anxiety disorder, major depressive disorder. Okay, other than that, there is no need. Dr. Arshan will cover all the theory for psychiatry. And DSM-5 criteria for all the criterias. Okay, this is a PDF available online. If you find on Google, you will find it. Uh, for the all the DSM criterias of psychiatric disorders. Okay, so the DSM criteria are basically, they have mentioned everything, and if patient symptoms fall into that criteria, then we call that, okay, this patient is having major depressive disorder because he is falling into the DSM criteria. Okay, so this is also very, very, very important, because in order to diagnose the psychiatric conditions, you need to remember the DSM criteria of all the diseases. For antibiotic choices, Australian therapeutic guidelines is always followed. It is in all the hospitals, this Australian therapeutic guidelines is followed. Okay, whether you are in the somewhere midway between your preparation and you were preparing, suppose for example, the USMLE step 1. So the difference would be only in the treatment or the investigation things, right? Because the pathophysiology, the history, the clinical features, they never change. But for example, if for some disease, the step 1 says that you have to give erythromycin, but in Australian guidelines, it say that you have to give azithromycin. Okay, so you will be going with azithromycin because you are going to give Australian exam. This is the only difference, where you, if you are studying from step 1, you have to follow Australian guidelines. Australian Immunization Handbook is also a website. If you type on Google, you will find it, and it has all the immunization criterias. Whatever MCQ you get about immunization, just Google it on this website, and a very good article will come, and you can have a look at it. Similarly, this is also a website for STI Guidelines Australia. And there is a red book for screening, like cancer screening, cardiovascular system screening, and all that. Just have to read cancer screening from such red book. Okay, so nobody tells you this, guys, that from where you have to study. I just made a list because, to be honest, when I was preparing for my exam, it was very difficult to start. Like, from where to start, I didn't know how to study. And this is the crux of everything from where I have studied, and I cleared my exam in first attempt. So, if you follow these things from the start, it would be very, very beneficial for you. So, let's start our questions now. This is from your AMC CAT exam PDF from their official website. See, they recommend RACGP, therapeutic guidelines, RCH guidelines, okay, DSM-5 criteria, and then this is RNCP, okay, Red Book, and other things as well. So all these things are recommended by Australian website, and they make MCQs from these websites. So picture of our first question is, yes, Emidex. Yes, of course, you have to solve Emidex. Emidex gives a very good idea about how questions come. Okay, so Emidex is a very good platform where you can practice MCQs. Picture of female patient with femoral hernia. So this question is coming with a picture. So now obviously the recaller hasn't given us the picture. So it is a recaller bias that this is a femoral hernia. Okay, that will depend upon the picture. But suppose the recaller is right and the picture is of femoral hernia. So let's go with the question. Presented with abdominal pain, vomiting, and constipation for 24 hours. Patient is tachycardic, febrile, and blood pressure is normal. What is the next management? So there is only one option here, that is surgery. So yes, the patient has constipation for 24 hours. It means that there is some sort of obstruction or strangulation going on. Okay, plus the patient has gone into tachycardia and he is febrile. He is going into septic shock as well. Okay, so it's very important that we take the patient to the operation theater as soon as possible. Femoral hernia, they are much more susceptible to obstruction as compared to the inguinal hernias, because you know that femoral canal, the neck of femoral canal is very narrow, and there is a very high chance that obstruction can occur. Okay, so this patient needs immediate transfer to the surgery for the to the operation theater. So now you can see in this recall, we have only one option. And this is a question where they gave a picture as well. So make sure that while you are studying the topic of femoral hernia, just look at the picture, the gross picture of all the hernias. Like where does femoral hernia lie, where inguinal hernia lies, direct, indirect, okay, epigastric, umbilical, all these hernias location. By looking at the location, you will have to look at what type of hernia it is. Okay, so surgical intervention remains the only cure. And if there is strangulation or obstruction, presents a surgical emergency. Dr. Puniba, what are you saying? I can't understand about emetics. Okay, so we have next question. Young male following high velocity motor vehicle accident, complaining of abdominal pain, blood pressure 85/60, pulse rate 120, and GCS is 12. Most appropriate next step: transfuse 1 pack O negative blood, IV normal saline, laparotomy or CT abdomen. So this is a question from emergency medicine part of section. Like this, such type of questions, consider them a pet question, okay? because they will always ask some question from the ABCDE protocol, resuscitation protocol. Okay, so as you guys know that ABCDE, A for airway, then breathing, circulation, disability, and exposure. First of all, you have to make the airway patent. For example, if the patient is speaking in sentences, so it means that airway is intact. It's patent. Then you have to move to the breathing step, and where you will look at the sounds from the chest, any abnormal sounds coming, any pneumothorax, any hemothorax, and you will treat that straight away before moving on to circulation. For example, in our patient, there is no mention, but we suppose that breathing is also fine. So now we move at the next step, which is circulation. Here, BP is blood pressure is 85/60 and pulse is 120. Okay, so we need to resuscitate this patient. We will pass wide bore IV cannula and then transfuse normal saline or any crystalloid to this patient. And meanwhile, we are passing cannula, we will take the blood sample for cross match because we are suspecting that there is some intraperitoneal, intra-abdominal bleeding going on, right? So before blood, we have to transfuse crystalloids. Meanwhile, we are arranging for blood. Okay, maybe this patient won't even need blood. Maybe his hemoglobin stays stable. So blood is a step that is somewhere further in our management. And about laparotomy, same that this is not the immediate next step, obviously. And CT abdomen is also not the immediate next step. CT abdomen requires that our patient is stabilized first. Okay, he is hemodynamically stable. Only then we can take the patient to for the CT abdomen. And for example, if you have E option as fast scan, then fast scan would be better than CT abdomen in diagnosing any bleeding somewhere in the abdomen. But again, first is A, B, C, D, E. You have to go according to that. Okay, so for example, in such a statement, they have given BP 85/60, pulse rate is 120, GCS 12, and they say something about oxygen as well. Okay, for example, they say the oxygen is 86%. So then just don't get distracted by this BP. You have to give oxygen first. Okay, always, even if it seems obvious, always go according to the ABCDE. This is the only approach that we adopt while being in emergency department. Okay, if airway is not patent, you can't move to the breathing because if you don't manage the airway, the patient will die within next few minutes. The patient will go into coma. Okay, so airway, breathing, circulation always go sequence wise. Yes, choice of solution is dependent upon the situation. Normal saline can be given, Hartmann can also be given. Whiteboard cannula we are passing when we have to transfuse, and we are transfusing when we are doing the ABCDE assessment. Okay, so that is definitely before the fast scan. Yes, for example, in your scenario, they have not mentioned the vitals, or they said that vitals are stable. Then obviously, you can go for fast scan option, right? Because we are suspecting that there is some abdominal bleeding, and so we need to find out where is that bleeding and how much is that, how much injury is there, so that we can decide whether we need to take the patient for the laparotomy or not. If breathing is impaired, for example, then for example, if there is pneumothorax or hemopneumothorax, then we have to insert the chest drain. Okay, so the main purpose of ABCD is that wherever you find any abnormality, treat it straight away. Don't move to the next step until you have completely treated this previous step. Okay, as long as you are treating airway, don't go to breathing. As long as you are treating breathing, don't go to circulation. Only then you can save your patient more effectively. ABCDE, there are Australian resuscitation guidelines, ARC. Just write ABCDE ARC on Google and you will find very good guidelines on over there. All right, so this is the link I've attached, how to assess a deteriorating or critically ill patient, the ABCDE assessment. So, next question. Middle-aged alcoholic patient presented with chronic abdominal pain for 3 months. On examination, he has normal lipase and amylase, high conjugated bilirubin. What is the next investigation? They have only given one option, which is CT abdomen. So, what can be the diagnosis here? The answer to the previous question was IV fluids, normal saline. Yes, conjugated bilirubin is now present in obstructive any disease which is causing obstructive symptoms. There is no mention of jaundice, but obviously, if conjugated bilirubin is high, patient will ultimately have jaundice as well. Right now, what important information we have that our patient is alcoholic. There is chronic abdominal pain for 3 months, and now there is high conjugated bilirubin as well. Okay, so what can be your differentials? There can be there is obstruction to the biliary flow. Either it can be due to the gallbladder, that is some stone in the common bile duct, it can obstruct the biliary flow, or there is some pathology of liver, like the patient is alcoholic, so maybe there is liver cirrhosis. Cirrhosis of liver also causes high conjugated bilirubin. And there is, along with this, there is pancreas is present as well. So any periampullary carcinoma as well, that can also cause obstruction. Okay, so all of these findings, whether intrahepatic, whether extrahepatic, okay, or whether it's self of uh, gallbladder or any common bile duct stone, CT abdomen is the one which can detect all of these things. The pancreas, periampullary tumors, the common bile duct stone, or any liver cirrhosis or any hepatitis. Okay, or it can be chronic pancreatitis as well, because normal lipase and amylase, it does not totally exclude your chronic pancreatitis diagnosis. You need further investigations, you need CT abdomen as well. Why not ultrasound? Yes, ultrasound can be the next investigation if you are suspecting that stone is the pathology that is causing your obstruction. Okay, if like I said, this scenario is not complete and we don't have enough options. If by reading your scenario you suspect that, okay, this patient is having stones, most likely gallbladder stones, then of course ultrasound would be the next step, because it uh, clearly tells that where are stones present. But common bile duct stones, the ultrasound cannot tell with much precision. Okay, so CT abdomen is better. And sometimes with these diagnosis in mind, like liver, pancreas, and the common bile duct, because you know, pancreas is a retroperitoneal organ, it cannot be visualized with ultrasound. So if we have an alcoholic patient who is having chronic abdominal pain for 3 months, so it means that there is some chronic pathologies going on. So we need to keep chronic pancreatitis, periampullary tumors in our mind as well. So why not do CT abdomen and diagnose or exclude everything, all the R differentials? Okay. Other than that, the other options, MRCP can be the next step when CT abdomen is inconclusive. All right. Or if we have suspicion that this patient has CVD obstruction, then we can go for ERCP as well. As you guys know that ERCP is diagnostic and therapeutic both. So if the patient has jaundice as well and he's having dark urine, pale stools, okay, he's having obstructive symptoms and we have to relieve the obstruction, then we can go with ERCP. We can take out the stone. We can, first of all, we can diagnose that, okay, there is a stone present in the common bile duct. We can take it out, removal of the stone, and we can put a stent as well over there. All of these things, that is diagnosing the condition and treating the condition, they can be done by the ERCP. Okay, and if the patient is not a suitable candidate for ERCP, then we can do percutaneous procedure where we PTC, where we can put the stent and decompress the biliary system. Okay. So our sequence is that first of all, we can do ultrasound if we are sure that there is some gallbladder pathology. If not, and if other differentials in mind, then we can do CT abdomen as our first investigation. After that, we can do MRCP, ERCP, and then PTC. All right, so according to this statement, where we have different diagnosis in mind, we can go for CT abdomen. So I have attached two links for bilirubin and conjugated hyperbilirubinemia and their differentials. Next question. Mother was worried that her 3-month-old baby had jackknife seizures, blank stare, otherwise well on exam, and there is no fever. So is it absent seizure, infantile spasm, or febrile seizures? So absent seizure is the one where the child stares blankly into his surroundings for a while and then he starts to continue whatever he was doing before that episode. There is no confusion after that episode, and these absent seizures, they are not dangerous. But infantile spasms, they have a blank stare. Along with that, they have jackknife seizures. What are jackknife seizures? There is sudden flexion of the body of the child, of the neck, of the arms, legs, and trunk, or there can be extension as well, which is sudden, and there is a blank stare. Okay, these are called as infantile spasms. Jackknife seizures, they're very specific for infantile spasms. And the infantile spasms, they can be part of the West syndrome. Okay, West syndrome is a triad basically. There are jackknife seizures. When you do the EEG, sorry, there is very chaotic rhythm, which we call as hypsarrhythmia. Okay, and there is blank stare. Blank stare and jackknife seizors, hypsarrhythmia on EEG, plus some neurological damage. Okay, these three things are for West syndrome. And these spasms, the infantile spasm, they are the part of West syndrome. Okay, so sometimes they can be used interchangeably, but West syndrome, as you know, syndrome is a thing where various diseases are present at the same time. So there is infantile spasm, there is hypsarrhythmia on EEG, and there is some neurological damage as well. So cognitive decline will be there or developmental delay would be there. Okay, so over here our option or answer is infantile spasm. Febrile seizure, it can't be because there is no fever. Also, this is not how a febrile seizure presents. Febrile seizures are generalized tonic-clonic seizures most of the times. Okay, blank stare either goes with absent seizures or infantile spasms. And jackknife seizures are infantile spasms. All right. And another difference is the age group. Infantile spasms, they occur in younger children like 3 months to 12 months. Okay, 3 to 12 months children, infants, they have infantile spasm. As you know, the word infantile, okay? But absent seizures, they typically occur in older children, like 4 to 10 years old. So absent seizures, they occur in typically older children, and there is no neurological decline. There is no developmental delay or developmental regression. Okay. Absent seizures, they are not an emergency, but infantile spasms, they are an emergency. You have to take the patient, the child to the hospital because there is developmental regression risk. Sometimes they occur as underlying cause of some other diseases like tuberous sclerosis as well. The treatment of infantile spasms is there is ACTH we can give, and there is vigabatrin medicine as well. ACTH is the first line. So I've attached the reference from the RCH, and it is a very good article. You can have a read from there. So next question is patient with multiple drugs during the day of surgery in the morning. What to do? Take ACE inhibitors, take beta blockers, or withhold thyroxine. So this patient is taking multiple drugs and he's having a surgery. So in the morning, what to do? He can't take ACE inhibitors. Okay, ACE inhibitors are such medications which we have to omit on the morning of surgery. Why? Because they can cause intraoperative hypotension. Okay, while the patient is on the operation table, the blood pressure can drastically drop. So that is why you need to omit the morning dose of ACE inhibitors. Other drugs which you need to omit are ARBs, angiotensin receptor blockers, and other ones are diuretics. Okay, if the patient is taking diuretic for his heart failure, then the case is different because heart failure patient obviously they're very much dependent upon diuretics, otherwise they can develop pulmonary edema quite severely. So that would depend on the case to case basis. Then if they are taking diuretics for some other thing, then you have to omit. Okay, another thing that ACE inhibitors cause is that they can cause metabolic or lactic acidosis. So that is why they are avoided before the surgery. Take beta blockers, yes, beta blockers are to be taken. If a patient takes beta blockers, then on the morning of surgery, there is nothing wrong. The patient can take. And it is beneficial to take beta blockers as well before the surgery because if you stop the beta blockers, it can cause rebound tachycardia. If you know that a patient who is on regular beta blockers, if they stop taking their beta blockers, the abrupt withdrawal of beta blocker, it can cause rebound tachycardia and hypertension. Okay? And sometimes myocardial ischemia as well. So that is why beta blockers you have to continue taking before the surgery. And because it helps them to maintain the hemodynamic stability. Thyroxine, thyroxine has a very long half-life. Withholding before the surgery, it won't have any difference. Okay, just skipping one dose does not make any difference. So whether you take it or not take it, it doesn't make any difference. So mostly patients, they take their thyroxine. There is no harm in taking it, but it would depend upon case to case basis again, like what is the level of the free T4 or TSH of the patient. Most of the times you continue the thyroxine. So from here, or the most appropriate option is that patient takes beta blocker on the morning of surgery. He has to avoid ACE inhibitor, he has to take thyroxine. Okay. ARBs also cause, they have a similar mechanism, according similar to the ACE inhibitors, and so they also cause this hypotension. Yes, if the patient is taking diuretics for heart failure, then they can continue their diuretics. And for beta blocker, I said that, sorry, it can cause rebound tachycardia if you stop the beta blocker. I have attached this reference. This is a Word document and it is Canberra Health. It is from the Canberra Health and they have mentioned all the medications that you need to continue or you need to omit. And also they have mentioned the effects which the medications cause. You don't need to memorize all, but as you will, solve the MCQs, You will get to know that how to read such articles. You don't need to memorize everything. Of course, that is not possible, but you need to learn the main things. Okay, so like in blood pressure medications, you learned today that you have to skip the ACE inhibitors, ARBs, and diuretics, but you can give other medications. Okay, so you can have a read on the over this article. So next question is, a patient presents with recurrent headaches and has a family history of brain tumors. Lab results show respiratory alkalosis with the following data. Oxygen saturation is normal, which is 95. PaCO2 is 27, it is decreased. And pH is 7.48, pH is increased. Okay, so this is respiratory alkalosis, the recaller has said. What is the most appropriate next step? Order a brain MRI, refer for psychiatric evaluation, start oxygen therapy, schedule a follow-up appointment in 1 month, or initiate carbonic anhydrase inhibitors. So this is a patient who we are suspecting that he is most likely having a brain tumor or a space occupying lesion. Okay. And since he has recurrent headaches and a family history, plus he is having respiratory alkalosis. Okay. Oxygen is totally fine. So starting oxygen therapy does not make sense. Oxygen is totally fine. When the oxygen is low, maybe we can give that. Right now, it's not required. Psychiatric evaluation, this is not the case of psychiatry right now. First, we have to look for some organic cause, and then we can, if we find nothing, then we can look for some mental causes, psychiatric causes, but this is not the case right now. Schedule a follow-up in 1 month. This is just gonna delay your diagnosis and patient will deteriorate. And initiate carbonic anhydrase inhibitors. We don't know what type of space occupying lesion is in the brain of the patient. Right now, we can't do that. Or most likely answer here is order a brain MRI. Because guys, this oxygen saturation being normal, PaO2 is decreasing and pH is increasing. So this is what we call as central neurogenic hyperventilation. Okay, so one hyperventilation, you know that when patient has anxiety, he hyperventilates. Okay, and then carbon dioxide is eliminated from the body, it decreases, and so pH increases. But on the basis of the history of the patient, there is some space occupying lesion. Maybe it is compressing the medulla and pons, that is the brain stem. Okay, so if it is compressing the brain stem, there is a diagnosis we call as central neurogenic hyperventilation. That is centrally in the pons and in the pons and midbrain, there is some tumor which is compressing it, and that is why the patient is hyperventilating. If we don't treat this patient as soon as possible, this patient can go into respiratory depression and coma. The sign that oxygen is totally normal, but carbon dioxide is decreasing and pH is increasing. It means that there is some central abnormality. If it was some lung abnormality giving respiratory alkalosis, or the patient had some anxiety having hyperventilation, the oxygen would also be deranged. Okay. But here it's not the case. Here the answer is brain MRI. It's not psychogenic, it's central neurogenic hyperventilation. That's what I'm trying to tell you. That central neurogenic hyperventilation is the one where there is pressure from some space occupying lesion. Its location is such that it is causing pressure over the respiratory center in the brain. Okay, that is what is causing this respiratory alkalosis. Okay, this is sometimes associated with brainstem tumors. And if we don't treat this patient, he can go into coma. This is sign of impending coma. So we need to order a brain MRI as soon as possible. We need to locate where the tumor is and start the chemotherapy. And we need to shrink this tumor as soon as possible so that we can correct this respiratory alkalosis. Okay, so temporary management can be that while we are waiting for the report of MRI and all that, we can put this patient on mechanical ventilation. Okay, we can put this patient on ventilator. We can assist his respirations. That he is hyperventilating, we need to control it. We need to give him artificial breathing. Okay, so that this respiratory alkalosis can get reversed and it will be normal. Meanwhile, we get the brain MRI report, and then we can start the chemotherapy, radiotherapy, whatever, depending on the or any surgical resection. That would obviously depend upon the type of the tumor, size of the tumor, and all that. That would be the definitive management. And meanwhile, we can keep this patient on mechanical ventilation. Okay, so if you see any option of mechanical ventilation, that can be the next step as well, because we need to treat this respiratory alkalosis first. Okay, and since we are suspecting that this is a brain space occupying lesion, so from these five options, brain MRI is the most suitable one according to our diagnosis. Carbonic anhydrase inhibitor, there is no role in such a scenario. They can be used in high altitude like sickness or any metabolic alkalosis, but they are not used for CNS pathology. The indication of mechanical ventilation in this case is that patient is hyperventilating. If he will soon, this respiratory alkalosis will become so severe that he will go into coma. Okay, so we need to correct it, we need to artificially correct it. Mechanical ventilation, obviously, we don't need to control his heart, just the breathing. We have to support the breathing of the patient. He's hyperventilating, we need to control the breathing rate. Yes, mechanical ventilation, any, which either by invasive or non-invasive, anyone. Okay, so this is the central neurogenic hyperventilation. Okay, so once is determined possible cause, the location is verified using the brain MRI. How to diagnose the cause of condition strep pneumonia related effusion in a 5-year-old girl, X-ray given high fever, serum pneumococcal PCR, blood culture or pleural aspirate. So this is a question where the caller has written that this is the condition of strep pneumonia related effusion. They will not give you the statement like this. Okay, like I told you, they will give you a proper scenario like a 5-year-old girl presents to the emergency department having high fever and all of these symptoms, okay, coughing and sputum as well, and then X-ray is given. So X-ray will be given in, okay, this question also is coming with the picture. So X-ray will be given to you and you will need to see that how much effusion is there. Okay. So effusion, what is effusion, guys? Effusion is some fluid in the lungs, right? So when there is pneumonia, it doesn't necessarily mean that effusion is also containing some bacteria. Okay, when there is pneumonia infection, and it is like you can say that it is a response of the body that fluid accumulates around that. Okay, so it can be sterile as well. That is, it does not necessarily mean that there is some bacterial inoculation over there as well. So we call that effusion as simple effusion, where there is no invasion of bacteria right now. It is a sterile fluid just in the lungs, around the lungs. So that we call as simple effusion. But complicated effusion is the one where there is invasion of bacteria. For example, there is high fever for more than 48 hours. It is not improving even with antibiotics, and now there is effusion as well. So most likely it can be complicated effusion, such that the bacteria have invaded now and it is not improving. The condition of the girl is not improving. Sometimes when the bacteria inoculate in the effusion, there can be septations as well. This is also complicated effusion. Okay, so how can we differentiate between these two, simple and complicated effusion? With a chest ultrasound. Okay, chest ultrasound is a very, sensitive and specific test for diagnosing this sterile effusion or complicated effusion. Okay, so if anyone is thinking about the pleural aspirate, please don't think right now because it is an invasive procedure, and in just a small 5-year-old girl, it is not a quite a recommended procedure. Okay, so RCH says that first line is blood culture. Although blood culture will not, isolate the bacteria. 50% of the times it does not show any results. But still they say in pediatric patients, you can do the blood culture first. And then you can do the serum pneumococcal PCR. Okay, so first blood culture, then as a second line, serum pneumococcal PCR. And if the child does not improve after 48 hours, and we have a suspicion that there is, and if we see on X-ray that there is very large effusion, for example, these are the lungs of the child, okay, and you see that there is very large effusion. So, and you know that we need to drain this effusion. So when you will put a drain to drain this effusion, at that time you can take some aspirate for culture. Okay, at that time you can do the pneumococcal PCR on that aspirate. You can do the gram staining, you can do the antibiotic sensitivity, the pneumococcal PCR, you can do all those things only when you decide that you need to drain this fluid. Otherwise, if there is no drainage in plan, then there is no need to d- diagnose the condition on the pleural aspirate. So I have attached the reference from the RCH guidelines, the parapneumonic effusion. Just a summary of this, I've written that if it is small effusion, first we can do blood cultures and then serum pneumococcal PCR. And if it is moderate to large effusion, it means that we need to drain it. Then we can take some fluid for microbiological gram staining, culture, pneumococcal PCR, and antibiotic sensitivity. Okay, so you need to read your whole statement that where on what stage your statement has stopped, and now you have to choose an option. Okay, so for every candidate, they will give some different scenario. So you need to make sure that your concepts are clear that when we are doing blood culture, when we are doing serum pneumococcal PCR, and when we are doing the pleural aspirate. So pleural aspirate only for when we have very large effusion and we need to drain it. Only then we can take some fluid for aspirate for the culture. See, this is the reference from the RCH guidelines. Nowhere they have mentioned that they are doing some pleural aspirate PCR, pneumococcal PCR. So they are saying that severe pneumonia or effusion is suspected. Okay, we do the chest X-ray. They have done in the scenario the chest X-ray, okay? And the recaller has not mentioned anything about how much effusion was present in the chest X-ray. So we can't say anything for sure right now. Okay, just we can make our concepts clear. So we have done the chest X-ray. If there is no effusion or very small effusion in a well child is the one who is eating and drinking normally, who there is no oligouria, there is no sign of dehydration. Okay, he is alert, he is active. Such a child, we can just prescribe him antibiotics. Okay, but if on chest X-ray, if very large effusion you see or moderate, or even a small infusion, but a child is unwell. So now the child is not that alert, he's being drowsy, he's not eating well, he's having oligouria, he's having signs of dehydration, anything present. So now you have to give IV antibiotics. Okay, so now you'll admit the patient, you will give IV antibiotics, and then you will do chest ultrasound. Okay, if you know such steps, then you can, any type of question comes, you can solve it easily. Okay, but if you learn from this question that okay, we did the blood culture as the option, then obviously you will fail your question because every question will be different in the exam. So chest ultrasound is differentiating between simple effusion versus complicated effusion. Okay, for simple, we are just giving IV antibiotics for 24 to 48 hours. But for complicated, we are going for intercostal drainage. Now, at this time, we can take a pleural aspirate if we want. Okay. So, in simple effusion, if there is clinical improvement, yes, then just discharge. If no, then go for drainage. So, this is a very simple flow chart and you can follow it and solve your questions. Giving antibiotics would obviously derange your culture and sensitivity results, but that would depend upon the condition of the child, whether he is improving or not, whether we need to change the antibiotic, whether we need to check if any other antibiotic sensitivity. So that would depend upon case to case basis. So next question is pregnant woman, 18 weeks, presents with severe headache and it was like a band-like sensation. Vital signs are stable. On arrival, she was confused. Neck stiffness is present. So, what is the next investigation they're asking? CT scan, urine protein, or glucose? Why B option, guys? Most of you are saying B. See, neck stiffness and confusion. This is so much a red flag sort of thing. Maybe this woman has some hemorrhage into her brain and we need to rule it out as soon as possible. Okay, so CT scan is the most important thing here. She's having headache. She's having band-like sensation, although her vitals are stable. But most important thing, she's confused and there is neck stiffness. So it can be subarachnoid hemorrhage, or there is another thing which is called as pituitary apoplexy. Sometimes there is pituitary adenoma in the pituitary gland, and it can rupture, causing sudden hemorrhage into the pituitary gland. And it mostly occurs in pregnancy. So such patients also have frontal headache and diplopia, hypotension. Okay. So basically that is also bleeding. So either subarachnoid hemorrhage we have to look for or pituitary apoplexy. So we have to do the CT scan as soon as possible. Okay. And about the urine protein, okay, you are maybe thinking about preeclampsia or eclampsia. That is also correct. But for preeclampsia and eclampsia, the diagnostic criteria is that it starts after 20 weeks. Okay, so our patient is 18 weeks only. We can't do we can't diagnose preeclampsia before 20 weeks. So if you search in the SA Health guidelines, just write preeclampsia SA Health, so it will give all the diagnostic criteria. Why CT in pregnancy? It is a risk versus benefit type of thing. If there is a subarachnoid hemorrhage going on inside the brain of the mother, and if you can't save her life, then obviously you can't save the fetus's life. So it is always a risk versus benefit thing in pregnancy. So if our diagnosis based on the confusion and neck stiffness, it can be subarachnoid hemorrhage or pituitary apoplexy, or it can be meningitis as well. But based on this confusion, she is deteriorating mentally, so we need to do CT scan to rule out the bleeding. Okay, 17 years old schoolgirl with complaint of prolonged irregular menstrual periods and heavy blood loss. Most appropriate treatment: COCPs, IUCD, mefenamic acid, POP, or Mirena. So now this is an adolescent female, 17 years old. She has menorrhagia and dysfunctional or abnormal uterine bleeding. So, what is the thing that will manage both of these conditions? Mefenamic acid is an NSAID, and does it manage your irregular periods? No. In an adolescent, Mirena is also not a good option. We can give, but COCPs are preferable. Okay, RCH says that COCPs are the first line. POPs can be given if there is some contraindication to COCPs. For example, any thromboembolic condition of the patient, or there is some cardiovascular risk. All right. And in those cases, we can give POPs. IUCD is not a good option because it includes both Mirena and copper. So copper one has no role. So B is not a better option. Mefenamic acid, yes, it can be used for heavy blood loss. But mefenamic acid is only used during the menstrual period, that is the 5 days or 6 days, when there is heavy blood loss. It only controls the blood heavy bleeding. It will not solve the irregularity. So we are giving the COCPs in adolescents, okay? The 15, 16, 17 years old. Yes, combined includes both estrogen and progesterone. Okay, so I have attached the reference from RCH. They have written a very good article about it. And there's another article on Royal Women Hospital website. So there's a similar, okay, this one, just see that OCPs, they reduce the bleeding by 40%, while POP or mini-pill, it reduces 85%. There is quite a difference in this, but POP side effects see that it may cause irregular bleeding. Okay, so we are trying to solve the irregular bleeding. So we need to use the OCPs, which helps keeps the periods regular. Okay, so if you try to look at Australian guidelines, everything is there on the websites, guys. So you just need to know how to search different websites. Similar question, here the age is different. 32 years old female now, who presented with complaints of heavy menstrual periods. So now she's having menorrhagia. Ultrasound uterine thickness is greater than 4 millimeters. What is the most appropriate treatment? COCPs, POP, Mirena, mefenamic, or IUCD? So now this is an comparatively older lady as compared to the previous one. She's 32 years old, okay? So in such females, Mirena is the best option. They have written ultrasound uterine thickness greater than 14 millimeter. So you know that throughout the menstrual cycle, uterine thickness varies. Okay, so in menstrual phase, it is just like almost 2 to 4 millimeters. Then comes the proliferative phase, which is like from the day 6 to 14. The endometrial thickness increases. And then comes the last secretory phase, day 15 to 28. And then there on the effect of progesterone, endometrial thickness even increases further. And it can range from 14 to 16 millimeters in a woman aged 30s to 40s. Okay, so now this depends upon the phase of the cycle where the woman is right now. The recaller hasn't mentioned anything like that, so we are suspecting that maybe it is in the secretory phase. Okay, but make sure that you read in the statement that which phase the woman is right now. If it was some elderly lady, very elderly, like almost in 50s, then obviously this 14 millimeter would be concerning for us. And first we will need to rule out any sinister causes of this thickness. And then we can treat her heavy menstrual periods, right? We can give POP, we can give COCPs as well. But the first line in 30-year-old female is Mirena. Then we can give COCPs. If COCPs are contraindicated for some reason, we can give POP. All right, and mefenamic acid is used for painful periods or heavy menstrual periods, but it is not that of a first line option. I have attached various references from different Australian guidelines. Okay, so this is just some showing that endometrial thickness can vary in different phases of the cycle. Okay, so the most effective is intrauterine, and which releases progesterone into the local area and can also be placed for up to 5 years. Okay. So next question, guys. Let's do this question, then we'll have a break. 45-year-old female complains of 2-day history of shortness of breath and dizziness. Vitals are blood pressure, respiratory rate, pulse were stable. Non-smoker, non-diabetic, not hypertensive, normal chest X-ray, normal ECG, most appropriate investigation. D-dimer, CTPA, VQ scan, do nothing and discharge. What's the diagnosis here, and then what's the answer option? So you are suspecting pulmonary embolism, right? Yes, that's correct. We are suspecting pulmonary embolism because she's presenting with shortness of breath and dizziness. Okay. But on what basis are you saying that we have to do CT scan or CTPA? Have you guys applied the well score? So what does the well score say? Is the PE highly likely or unlikely? What is the pretest probability? So Wells criteria says that PE is unlikely. So our patient, if we apply the well score on our patient, PE is unlikely. And then after PE is unlikely, what do? We apply another criteria which is called as Perk rule. So what most of the people do, they don't apply Perk rule and they just go for an option. Perk rule is as important as Wells criteria. So what is Perk rule? This is simplified well score. You can use the other well score as well, where the score is less than 4 or greater than 4. Any one of these is equal. You can use any one. Okay. The result is always the same. So we applied the well score and our patient is having unlikely diagnosis, score 0 to 1. Okay. So now what we have to do, we have to apply the Perk rule. So this is a Perk rule. Age less than 50, yes. Our patient was 45 years, I think. Pulse less than 100, yes. Our patient pulse rate was normal. Oxygen greater than 95 on room air, yes. Our patient had normal vitals. No exogenous estrogen, nothing mentioned in the question, so we are assuming that this is also the answer is yes. No prior venous thromboembolism, yes, there is no such history. No surgery or trauma in the previous 4 weeks, yes, there is no. Nothing like that. And no unilateral swelling, yes. So answer to all is yes. Okay, so our Perk rule, answer to all is yes. So no further investigation is required in this patient. Okay, so this is from the RS-CGP guidelines. You performed well score. Your PE was unlikely on that score. Then you apply Perk rule. Answer to all was yes. Then no further investigation is required. We can discharge the patient home. Okay, and we can most likely, maybe due to some anxiety or anything, okay, we'll just counsel the patient and send her home because all the things are normal, chest X-ray, ECG. She's not having any comorbidities even. Okay, so that is why we can discharge her home. For example, if your patient was 55 years old, okay, so right now our patient is 45. right? For example, in your scenario, it was 55 years old. Then your answer to this one would be no. Then no to any, then you will have to perform the D-dimer. All right. So after performing D-dimer, you will see that, okay, if D-dimer becomes positive, then PE is likely. And then you will have to do the imaging, whether CTPA or VQ scan. And if D-dimer is negative, you can easily exclude the pulmonary embolism. And then again, no further investigation would be required. Or if for well score, the score was greater than 4, or in simplified well score, it was greater than 2, then PE is likely and we are directly doing the imaging, the CTPA or the VQ scan. Right, guys? Yes, I've attached the link over here. This one is the link from the RACGP, and I've taken the screenshot from the same link. So we apply PERC rule, we apply Wells criteria and PERC rule, and then we make sure to rule out all the factors and then do nothing and discharge. So basically for pulmonary embolism, you just have to see two things. You just have to remember two things, Wells score and PERC rule. First, we will apply PERC rule. If unlikely, first we will apply Wells score. If unlikely, then apply PERC rule. Answer to all, yes. So that is the thing about pulmonary embolism. Well score is also given over here. Okay, so it says that there are clinical signs and symptoms of DVT. Our patient does not have this. Immobility or surgery in the previous 4 weeks. Our patient does not have this. Previous venous thromboembolism, no history of in a such patient in our patient. Hemoptysis, no episode. Malignancy, no episode. Uh, Alternative diagnosis, no, we are thinking pulmonary embolism. Heart rate greater than 100, no. So our patient score is 0. So our Wells score is 0. So it is unlikely. Or pulmonary embolism is unlikely. So that is why we are going on this pathway. And then if it is unlikely, then we have to apply the PERC rule. If, for example, our patient had hemoptysis episode and heart rate was also greater than 100, okay, and there was previous thromboembolism history as well, then score was 3. Okay, so it was greater than equal to 2, then pulmonary embolism was very much likely. And then we would directly go to CTP or VQ, then there would be no role of PERC rule. Yes, Dr. Aryan, we are suspecting PE on the basis of shortness of breath only, because our options show D-dimer, CTPA, VQ, everything according to the pulmonary embolism. Maybe the recaller has missed something. That is why you are thinking that just by SOB, we are thinking PE. Maybe in the recall, there would be some, in the original question, there would be some other important point as well that is leading us to the pulmonary embolism diagnosis. Okay, so the whole statement, maybe it would change your answer, guys. Please do not remember this answer. Do not memorize it. Memorize this flow chart so that any type of question comes in exam, you'll be able to solve it. So let's just take a break of 10 minutes. Then we'll be back for other questions. Regarding the file upload in the portal, I'm sorry, I don't have the authority for that. Dr. Arshan will be the better person to ask such questions. Yes, 10-minute break, guys. Hello, everyone. Yes, can you guys see my screen? Okay. Yes, antibiotics you have to start as soon as you know that the child is having pneumonia. There is not always accompanying parapneumonic effusion with the pneumonia, but if effusion is not resolving or the child is not getting better with antibiotics, then we try to think, okay, she might have some new effusion going on, or on investigation, or sorry, physical examination findings suggested there is some dullness in the chest, then we can think that there is some effusion. And after X-ray, we can go for ultrasound of the chest. Okay. So again, very short question. Pregnant lady has genital warts. What to do? There was no option of cryotherapy. Leave it till delivery. So this question will never come like this, guys. They will never say that the pregnant lady has genital warts. They will describe the wart for you, okay? So that is why you need to know that how a wart is described, okay? What is a wart? What is the description of certain different dermatological conditions, okay? So genital warts, the benign ones, they are caused by the human papilloma virus type 6 and 11, as you know, which are the non-oncogenic. The cancerous ones are others, the 16 and 18. We're not talking about those. The benign ones, now the pregnant lady has those warts. Now what to do? The recaller is saying that there was no option of cryotherapy. So leaving it till delivery seems a fine option to me right now, depending on this much statement. This is the table showing that the treatment for warts in pregnancy. See, first you do the expectant management, that is, you just observe, you just wait and watch, because in pregnancy, sort of immunocompromised state, right? They're prone to infections and all that. But as soon as after delivery, the immunity gets better, uh, there is regression of these warts. They resolve by themselves, okay? They improve spontaneously following pregnancy. And whether we treat it or not, they usually regress. So wait and watch is seems like a suitable option if the warts are not causing any significant distress. If the warts are recurring, or they are increase in size or number, or they are causing some obstructive symptoms, or they are present in the cervix, okay, then we can do the cryotherapy. But the recaller says that the cryotherapy was not in the options. So what is the third line? Trichloroacetic acid. And fourth line is surgical ablation. Okay, so the most suitable option is to leave it till delivery. After that, it will resolve on its own. If it doesn't, or it gets increased in size, then we can go for other options. Okay, and by that time, pregnancy will be over. So other treatment options like podophylotoxin can be given as well. Okay, so podophylotoxin, interferon, 5-fluorouracil, they are contraindicated in pregnancy, but in non-pregnants, usually they are given first as compared to this TCA. Imiquimod is also not limited in pregnancy. Surgical ablation is reserved for large obstructive lesions and should be deferred until third trimester to minimize the recurrence. Okay, so pregnancy is sort of a vulnerable condition where the warts, if the patient has warts, and if you, for example, if you treat it in first trimester, so there's a chance by the end of third trimester, the patient will have them again. So it's better that you delay this surgical ablation, even if you have to do, you do it until third trimester so that during the delivery, there is no problem, there is no obstructive symptoms. obstructive lesions, and so the delivery can be done easily via the vaginal delivery. Okay, and they do not, there is no viral shedding. Okay, there is no vertical transmission of such warts, so you don't need to worry that we have to do C-section for such benign warts. Okay, so first is to leave it till delivery, or we can do cryotherapy depending on the condition of the wart. So here, leave for delivery seems a suitable option. Can you guys hear me properly? Okay, thank you. Okay, so I've added this question in order to tell you that STI Guidelines Australia is a very good website to read the sexual and these such conditions. Okay, so two links I've added. You can have a read from this from these guidelines. If the option has cryo, I would say still the better one would be to leave it till delivery. Because the caller has just said that this is genital, the pregnant lady has genital warts. We don't know how much number is there, or whether it is recurring, or whether it is in the cervical canal, or it's causing obstructive symptoms. Okay, so obstructive lesions that would hinder the pregnancy, the vaginal delivery. If such conditions are there, then we can go for cryotherapy. Okay, if it is not troublesome, it's just there and it's on the external vaginal canal or thing, or just it's not troublesome, or it will not cause any hindrance in the delivery of the fetus, then there is no need for cryotherapy as well. Just leave it till delivery, wait and watch after delivery, it will regress on its own. A pregnant lady in her 36 weeks gestation had GBS positive, group B streptococcus, result at 12 weeks. Okay, so she had GBS positive at 12 weeks and received 5 days of penicillin. What to do now? Intrapartum antibiotics, or treat her newborn, or do nothing at all? So this patient had GBS positive result at 12 weeks. Even though she was treated for it with penicillin, still we need to give her intrapartum antibiotics. Why? Because this is a prophylactic treatment so that the newborn may not develop early onset neonatal sepsis. Okay. Even if the woman had GBS in her previous pregnancy, we would still give her intrapartum antibiotics in this pregnancy. Okay, so there are certain conditions that you need to remember, that where you have to give the GBS prophylaxis, right? So we are giving intrapartum antibiotic prophylaxis for any woman who has positive GBS culture from the low vaginal swab or the rectal swab. All right, previous child with GBS infection, regardless of the present pregnancy cultures. For example, if a woman had a GBS infection in the previous pregnancy, but right now the culture shows that there is no any sign of GBS infection, still we would give her intrapartum antibiotic because she was once colonized with GBS infection. So there is a high chance that this fetus, this child can also get early onset neonatal sepsis. So it's important to give her intrapartum antibiotic prophylaxis. Symptomatic or asymptomatic GBS bacteriuria, even if there is bacteriuria, in current pregnancy, we are giving her intrapartum antibiotic prophylaxis, and any unknown culture or no screening in pregnancy and risk factors are present. Okay, and this one also says that if it is detected in urine, we give intrapartum prophylaxis. This screenshot is from Australian therapeutic guidelines. And this one is from, I think, Ranscog. Okay, so what is the treatment of, what is this prophylactic antibiotic we are giving? We give usually IV benzyl penicillin. And if the patient is allergic to penicillin, then we can give cefazolin or clindamycin, depending upon the sensitivity, okay? The first line is IV penicillin. Okay, so the next question is that a 19-year-old male presents with fatigue and jaundice. On examination, patient is pale and icteric. Investigations, hemoglobin 6, very low. Retics are 5% increased. MCV is high, 104. Total bilirubin is 54, out of which unconjugated is 50. So what is the diagnosis? G6PD, hepatitis, or IDA, iron deficiency anemia? So this is a case of G6PD deficiency, an easy question, where a condition where you have pallor and icterus both, for that is anemia, as well as jaundice both. It is some hemolytic cause, right? Some hemolytic anemia. And from these three options, this one is the hemolytic anemia, G6PD. And 19 years old male, G6PD mostly occurs in males, it's an X-linked disease. And there are certain triggers, like, for example, during any oxidative stress, like any infection, any drug the patient is taking, like naphthalene or those mothballs, right? Uh, mm, uh, or he's taking any drugs like dapsone, and if there is any infection in the body, or fava beans as well. So there are some certain triggers which cause G6PD deficiency. If the patient is G6PD deficient, such triggers can cause jaundice and anemia. Okay. Hemoglobin is 6 and retics is 5. It means that hemolysis is going on and bone marrow is trying very hard to overcome the red blood cell destruction. So the retic count is high. Normally in hemolytic anemia, we have normal MCV. The hemolytic anemias are mostly normocytic, right? But even if you have some sort of high MCV, this 104 is not that of a significance because the retics is high, okay? Reticulocyte count is 5%. As you know, what are reticulocytes? They are immature red blood cells, okay? They are larger than the normal red blood cells. Normal red blood cells are kidney shaped, they are circular and they are larger. So that is why this is falsely elevated MCV 104, because the retics are present in the blood and they are larger in size. So that is why on report MCV, the MCV is high, almost like in this scenario, it is 104. But in macrocytic, proper true macrocytic anemias, that is B12 deficiency or folate deficiency, this MCV is usually very high, like it is greater than 110. Okay, so that becomes significant. Plus, there are no retics in macrocytic anemia. Okay, so you have two missing options. Maybe they would give you B12 as well because of this MCV high. So don't get confused. Here the retics are also high. That is why it's falsely elevating this MCV. Okay, so we have anemia, we have jaundice, and maybe there is some trigger in this scenario as well. So most likely it is G6PD deficiency. Iron deficiency anemia would cause microcytic anemia. The MCV would be low. The retics would not be raised. Unconjugated bilirubin or things like that would not raise. And hepatitis would have other things as well, like ALT, ALP would be raised. Okay, liver function would be deranged. So I've attached the references as well. Okay, so now next question is that 5-year-old girl, her brother had sore throat like symptoms 1 week ago, presented with fever for 72 hours, cervical lymph nodes enlarged bilaterally, red tongue and skin rash. What is the causative organism? Staphylococcus, streptococcus, Haemophilus or Coxsackie virus? So the red tongue, most likely strawberry tongue with a skin rash, the sandpaper-like rash. Cervical lymph nodes are there. Brother had sore throat previously. Fever is there, which is there for 72 hours. Most likely, this is some streptococcus infection, any scarlet fever, okay? Staphylococcus aureus also can cause, but this red tongue, skin rash, that is not very pathognomic for Staph aureus. It can cause skin infections, but it mostly cause other types of infections, not a skin rash. Okay. Hemophilus, it can cause epiglottitis, otitis media. Okay, it does not present like this. And Coxsackie virus, you know that Coxsackie virus causes hand, foot, mouth disease. Okay, there would be ulcers in the mouth, around the mouth. There would be ulcers or blisters on the rash, blisters on the palms and soles. And usually, Coxsackie virus, the fever is not this high. When the fever for 2 to 3 days settles down, then the rash appears, and then it also, in few days, it goes. There is no sore throat in Coxsackie virus, no lymphadenopathy, and no red tongue. Coxsackie virus does not present like this. So most likely it is a streptococcal infection which is causing skin rash, beefy red tongue, and cervical lymphadenopathy with sore throat. Also, the age group is very good for streptococcus. Kawasaki disease, yes, it can be, but you suspect Kawasaki when there is fever which is there present for 5 days and it is not getting well. Okay, then you suspect Kawasaki disease. It is a medium vasculitis infection of the medium-sized blood vessels. So most likely diagnosis is scarlet fever, and I have attached the sore throat guidelines from the RCH. It includes all the things, all the differentials like epiglottitis, quinsy, scarlet fever, all these things, the clinical features of those and treatment. So next question is, aunt brings her 14 years old girl who is sexually active for contraception advice. What is the appropriate next step? Inform parents, give contraception, or assess for ability to give consent. So this is a 14-year-old girl. So this question is related to the Gillick competency. Gillick competency is used for minors, that is, children or adolescents under 18 years of age, where we have to decide that whether they can give consent or not. Okay, so in Australia, under 18 can give consent for various conditions. You just have to assess them for the ability to give consent. Okay, so what you will do, you will you will tell the patient or this 14-year-old girl about all the contraceptive advice, like all the options she has. What are the risks and benefits of everything? What can be the complications? What risks are there? And you will assess whether she's able to understand and then reproduce all the information. If she's understanding all the risks, and she says that yes, I understand, and this thing can happen, and I'm willing for this type of contraceptive advice, then you can give her. Okay, 14 years old. There are some NSW guidelines, New South Wales guidelines on consent of minors, where they have clearly written, they have given various scenarios, and they explain that how this patient can give consent, how this child can give consent, and how this child can't give consent. Okay, so they write that a 14 years old girl or 14-year-old boy, uh, if like a 14 to 15-year-old child, you can expect that they will understand the contraception or vaccination risks and benefits and all that, and they will be able to give consent for such things. But if you expect a 14-year-old girl to consent for heart surgery, then obviously she would not be able to understand all the things. Okay, so for heart surgery, you cannot assess the patient 14-year-old. For example, if it was written that aunt brings her 14-year-old girl who is planned for some heart surgery for some congenital heart condition or whatever, what is the appropriate step? So now we are going to inform parents in that condition. Okay, because you cannot expect that a 14-year-old girl will understand the risks that come with heart surgery. Okay, contraception is comparatively a very simple thing to understand, and a 14-year-old will be able to understand it. Okay, so this is, on the other hand, if the child is 17 years old, then there would be many things that he would be able to understand as compared to when he was 14 years old. Okay, so this is what is Gillick competency, that you have to assess the patient whether or not he is understanding the condition, the risks that come along, the benefits, the complications, all the things of that procedure, and whether the child is able to understand and then reproduce all the things that he has just listened. Then we can allow the patient to give consent or to reject or whatever. Okay, so usually the NSW guidelines say that usually 14 years old, they are able to give contraceptive advice, contraceptive consent. Okay, so we can first assess and then we can give the contraception advice, contraceptive method, whatever she's asking for. Okay, same goes with vaccination and very many minor procedures as well. Okay, so I have attached this one. This link is from the NSW guidelines. If you open it, there is like I think 12 pages PDF or like that. It shows every condition and it would explain Gillick competence in a very good way. Okay. This one is from the same PDF. Okay, so it says that significance of the proposed treatment will be relevant factor in assessing whether a minor has capacity to consent. For example, it may be likely that a 15-year-old would be assessed as having the capacity to consent to receive contraceptive treatment, but less likely that she would be assessed as having the capacity to consent to a heart transplant. Okay, for a 15-year-old girl, heart transplant is a very major thing, and we most likely she would not be able to give consent. She would not have the ability to give consent. Okay, so they're saying that we have to check according to the Gillick competent. And a child who is Gillick competent, it means that he's a mature minor. So now this 14-year-old girl, she's a mature minor. If she has the ability to give consent, then she would be a mature minor to give consent for contraception advice. Okay. So the minor, if he can give valid consent, then the consent of the parents or guardian will not be required. However, it is a good practice to involve the family in decision-making process. Okay, so even if the parents are saying something opposite, as long as the child is able to give consent, we have to listen to the child, considering that he is mature minor. Yes, if there is any emergency operation, so then we have to do whatever is better for the patient. Okay. There is no need for consent in emergency procedures if the procedure is life-saving for the child. Okay, so for example, compartment syndrome, yes, there is a threat to the limb of the child, and we want to save the limb of the child, and the parents are not there, then we can do whatever we want for the compartment syndrome, and after that we can inform the parents. Or if the parents are present and they are saying that no, we don't want that you treat the compartment syndrome, but we know that if we don't treat it right now, the limb would go gangrenous. He would lose the limb and then the gangrene would spread in the whole body and sepsis would spread in the whole body and the child will die. Okay, we as a doctor, we know that this thing can happen. So what are we going to do? We will override the decision of the parents and we will involve court. And the court will decide that whether uh, you can do or not. And if it is immediately life-threatening condition, then you can treat the condition, and after that you can involve the court. Okay, so in the emergency procedures, whatever is better for the child, you have to do that. All these scenarios, they are written in this PDF in a very clear manner. So next scenario is that a 31 years old lady requests permanent sterilization, has 4 children, husband doesn't want vasectomy but gives consent. What is the next step? Defer sterilization until 35 years. This is years. Give bilateral self-injectomy or laparoscopic hysterectomy. So, yes, we can do bilateral self-injectomy because the woman has requested it. She has 4 children, so most probably her family is complete. Husband doesn't want vasectomy and he is giving consent for bilateral self-injectomy. Although we don't need his consent, we need only the lady's consent here. So we can give her bilateral self-injectomy, yes. But some guidelines say that defer sterilization until 35 years, but Ranscock says 30. Okay, so under 30, if the patient, for example, this patient was 29 years old, we could have uh, chose an option where we are deferring sterilization because they say the reason they give is that under 30, the women maybe they are emotional and after 30 or 35 years they will regret their decision of having permanent sterilization. Okay, because this procedure is totally permanent, it is irreversible. So they say that at least 30 years, above 30 years, you can give or do the procedure. Below this age, just give some time to the woman so that she can think rationally whether she really wants such procedure, irreversible procedure or not. Okay, so some websites say that 30 years is the cutoff, and some say that 35 years is the cutoff. I personally could not find any PDF where it said 35. Ranscog, Australian Royal Australian College for Obs and Gynae, it said 30 years, and there is some FIGO guidelines. It said that it can be given at any age. Okay, so these are FIGO guidelines. They say that once the informed choice has already been freely made, that is, nobody forced her to for this decision. So sterilization should be made available to any person of adult age. Okay, so they have written no cutoff value for any age. All right, and they've also written that there is no maximum or minimum number of children that is used as a criteria. So even if she has one child and she's wanting sterilization, so we can give her as long as she's giving informed consent. She knows all the risks and complications of that. And a partner's consent is not required, although patients should be encouraged to include their partners in counseling. Okay, so this lady has included her partner in counseling, and the partner is also agreeing that yes, okay, we can go for this procedure. Okay, and this small thing is from the Ranscock that age of 30 years. So we can, under 30 years, we can do a proper counseling that you can, it's possible that you can regret your decision later on, so you can have some more time to think. We can counsel the patient, but if still she says that no, I want to go, so what can we do? It's the patient's decision, okay? So I've attached the links of both the websites. What if someone is forcing her? Obviously, then we cannot do. If the patient is not giving the informed consent, we cannot do it this to her. If there is someone forcing, then we need to involve um, other support workers and all that for the support of the woman. The right choice here is give bilateral self-injectomy because this woman is 31 years old. She's requesting, husband is also involved, that he says that okay, although his uh, decision is not required for this self-injectomy, but involving your partner is a good practice. And she has 4 children, so her family is also complete. So that is why we can give bilateral self-injectomy. Okay. So next question is a junior colleague asks from junior doctor to get a photograph of a patient's leg lesion. What do you do? Take a photo for him, ask the patient's consent and take photos, or refuse the request? So now we don't know that why does the junior colleague wants the picture. Okay, so they have not given any reason. So if we do not know any reason, we can ask the patient's consent and take photos. Okay. For example, if he needs to include that picture in a presentation or his research, then we can tell the patient everything, that this is the research we are doing and this is our article, and we need a picture because your case is quite unique, and it would be better if you give us the pictures. Only with the patient's consent we can take the photos, not without his consent. But there are some other recalls where the recall says that a doctor is asking for a photograph for his personal reasons. Okay, so then we will refuse the request because personal reason is nothing. We can't take the patient's photo for any personal reason. Okay, so over there we will refuse the request. But here, since we do not know the reason, so we can take the patient's consent and take photos. And also ask the colleague that why do you need this for the photo of that patient. Okay, so this is the best practice, that always act in the patient's best interest, always protect their privacy, and always follow the hospital protocols. So every hospital has their own protocols of what kind of photos you can take of the patient, medical photography, what is allowed, what is not allowed. Okay, so ethical considerations should be always kept in mind. The correct answer here in this scenario is ask the patient's consent and take photos. These are AMA guideline ethics, Australian Medical Association, I think. Anyways, these are Australian ethics rules. Okay, I've taken screenshot from that, that maintain the confidentiality of the patient's personal information, including their medical records, disclosing their information to others only with the patient's express up-to-date consent or as required or authorized by law. Okay, so this applies to both identified, de-identified patient data. Okay, so for any ethics questions, there are some general rules that you can have a look. It's a very small PDF and it just states things like this, generalized things. Obviously, the scenarios would be like a story or some mm, real life thing. Okay, so these are just rules and you can apply them in your scenarios, in your questions. Not necessarily written consent, informed verbal is also fine, but it should be informed consent. Next question is that refugee female came to Australia recently. Feeling of fear when husband is not at home, anxious when people are around, feels irritated with two kids. So this is adjustment disorder, generalized anxiety, or schizophreniform. So this is adjustment disorder. She has recently came to Australia and now she's when the husband is not at home, she's feeling very fearful. Okay, if it was generalized anxiety disorder, she would have felt it before as well, and there is a specific criteria for GAT, the DSM criteria. And schizophreniform, it's not schizophreniform. In schizophreniform, you have disorganized speech, hallucinations, okay, and delusions as well. And schizophreniform is that when symptoms last for less than 6 months and greater than 1 month. Okay, greater than 1 month, less than 6 months, then it is schizophreniform. If the symptoms last for greater than 6 months, then it becomes schizophrenia. The rest of the DSM criteria is totally same. So here she is just anxious because she has recently changed her area. She has moved to a new region and just she's fearful and when people are around. Okay, so that is adjustment disorder. She's trying to adjust to new place. So this is a screenshot from DSM criteria. Okay, so marked stress that is out of proportion to the severity or intensity of the stressor. Okay, and symptoms should occur within 3 months of onset of stressor. They do not represent normal bereavement and they last no more than 6 months. Middle-aged man with schizophrenia, well controlled on olanzapine. He presents with increased daytime sleepiness in workplace, also loud snoring, grunting in sleep, daytime sleepiness. Wife has to sleep in a separate room. Wife is threatening to leave him because of his snoring and she's irritable. What intervention will most help with the sleep issues? Reduce olanzapine, weight loss program, do nothing, sleep hygiene, sleep restriction. So this patient has schizophrenia and he's on olanzapine. We know that olanzapine side effect is weight gain. It causes metabolic syndrome. It is a very renowned side effect of olanzapine. Okay, but this patient, what he is having right now, maybe due to weight gain, he is having a condition called as obstructive sleep apnea. Okay, there is loud snoring, grunting, daytime sleepiness at workplace. Okay, and partner is very irritated, and so this is OSA. And what will help with the OSA? The weight loss program. Okay, the people who are thinking reduce olanzapine. First of all, the patient is well controlled on olanzapine, okay? If we try to disturb this olanzapine, what will happen that maybe this patient will develop some schizophrenia episodes, which we don't want. Okay, he's well stabilized on olanzapine. Secondly, olanzapine side effect, which I'm talking about, the metabolic syndrome, it is not dose dependent. Okay, so some drugs with they cause dose dependent, they have dose dependent side effects. For example, the drug that you use for gout, the colchicine, its side effect, very renowned side effect is diarrhea. Okay, but it is dose dependent diarrhea. When the patient develops diarrhea, you reduce the dose of colchicine and the diarrhea goes away. This is not the case with olanzapine. The side effect, metabolic syndrome, the weight gain, that is not dose dependent. Even if you give reduced dose, same amount of weight gain would occur. So this patient would not benefit, rather that would be harmful, reducing the dose, because his schizophrenia would come back. So for OSA, do nothing is also not an option. Sleep hygiene, this wouldn't be effective for anyone who is having some organic cause. Okay, and sleep restriction is also not gonna help. So from these five options, weight loss program is the best for obstructive sleep apnea. Apart from this, for obstructive sleep apnea, with the weight loss program, you can use CPAP or mouth guards, okay, for OSA. Good reference of side effects of antipsychotic drugs. The best I would say would be Australian therapeutic guidelines. They are very good at what happens after as a side effect of disease and what you need to do, reduce the dose or change the drug. Australian therapeutic guidelines is very good regarding that. Okay, so like I said, uh, the olanzapine, this is not dose related. All right, and I've attached the links as well. 16-month-old, 5 days vomiting. Okay, so he has vomit, he has 1 day diarrhea, and now he has developed seizures. Now intubated and unresponsive, no other physical findings, he's afebrile. Biochemistry values given all normal except sodium, which is 119, and chloride, they've not given the value of chloride. Asked for the most appropriate investigations: stool culture and virus, urine osmolality and sodium, blood culture, head MRI or abdominal CT scan. So now this patient, this 16-month-old child has sodium 119, which is severely low sodium. Okay, less than 120 is severe hyponatremia, and it can cause seizures, where in our patient it really has caused seizures. Even he's unresponsive now. Okay, so now we need to treat this hyponatremia as soon as possible. If in these options there was some correction of sodium, then please choose that option, because nothing is better than just correcting the sodium in the patient who has seizures and is unresponsive. Okay, but from these options, uh, urine osmolality and sodium would be the best option. Why? Because whenever there is decreased sodium, we pair it with uh, serum osmolality, urine osmolality, and urinary sodium. Okay, so that helps to differentiate that what is the cause of sodium loss. Apparently, this child has some gastro issues, like he was having vomiting and diarrhea. So maybe sodium loss is happening from there, but we need to differentiate that whether his kidneys are functioning fine or not. Okay, so in order to look at the kidneys, we need to check the urine osmolality and sodium, that how much kidney is able to do able to excrete the sodium. Okay, if kidney sodium is urinary sodium is increased, then it can be a renal cause. Okay, or other than that, it would be SIADH, it could be GI causes. So these values would vary in all these diseases. Okay, so we need to differentiate, only then we can treat. Immediate management would be to treat the sodium. Make sure that you do not correct it rapidly. You correct it over multiple hours. Okay, and since they are asking about investigation, then that would be urine osmolality and sodium. Okay, stool culture and virus. Yes, this child has vomiting and diarrhea, but right now he's unresponsive. He's having seizures. There is no role of stool culture, as in, what is it gonna change the management? How is it gonna change the management? Okay, if we find the stool culture, first of all, the report would come in a few days. Culture takes time. Okay, even if it takes one day, our child is unresponsive, he's having seizures, we need to do something as soon as possible about it. Okay, so this is not the most appropriate thing. Blood culture, same, it would take time. Head MRI, there is nothing, no intracranial pathology we are suspecting right now. Our lab value shows that sodium is 119. We need to compare it with urinary sodium and urine and serum osmolality. Okay, so that is the important thing here. Same with abdominal CT scan, we are not suspecting any other pathology right now. Okay. Yes, slow correction to avoid pontine myelinosis, because if you rapidly correct the sodium, it can cause the demyelination. If sodium is normal, then what will be the more appropriate MRI or CT? If sodium was normal in this situation and child was having seizures, then the more appropriate diagnosis would be meningitis. Then we would go with the blood culture then. Okay, so if sodium is less than 130, you do paired serum and urine osmolality and urine sodium. You check blood sugar and blood gases. Okay, this guideline is from the RCH guidelines. No, doctor, diazepam is not used for hyponatremia seizures. Like, just correct the sodium. The seizures would automatically be uh, treated. So let's be quick, guys. Foreign body magnet scenario: two magnets ingested by a child. X-ray or so after 6 and 12 hours show battery has not moved. Both magnets are seen close to each other, and child is asymptomatic. So reassure and send home. Repeat X-ray in 24 hours. Refer for surgery. Serial X-ray. So this two magnets. This is a very important thing here. Most important thing in this scenario, that magnets are seen close to each other on X-ray. What if there is a bowel wall in between those two magnets? Okay, for example, if you see two magnets lying like this, what if there is a bowel wall across these two magnets? Then in no time they will call the bowel perforation. Okay, so magnets, one magnet plus one metal object or two magnets, they are a red flag for children and they need immediate surgical treatment. Okay, they need immediate surgical removal. So this is also from the RCH guidelines. Now, anything that is written in red in RCH guidelines is a red flag which needs urgent prompt treatment. Okay, so urgent referral would require where there is multiple magnet or single magnet plus metallic object anywhere in the GI tract. If there is single magnet in esophagus or stomach on X-ray, then early discussion. Okay, so 24 to 48 hours, it needs to be removed in 24 hours. And seek advice, single magnet beyond the stomach. If it is just single magnet, we can seek advice from the specialist, and whatever he will say, that whether bring the patient to me or within 24 hours surgery should be done, that would depend on the case to case basis. But this one, this is most important. It needs to have surgery right away. Okay, so next question is presented to emergency department. He cannot swallow saliva after eating beef in a restaurant. Nothing on question showing anaphylaxis. So what do we do next? Barium swallow, Heimlich maneuver, esophagoscopy, or ipecac syrup? So this is also one of the favorite questions of AMC. This diagnosis here is most likely what we call as eosinophilic esophagitis. Okay, EOE. What happens in EOE is there is allergy to some specific proteins or components of diet like wheat or milk products, okay, which cause the inflammation of the esophagus, and there is high eosinophil count. There is allergic reaction and there is high eosinophil count in esophagus. Prolonged eosinophil count causes strictures in the esophagus, stricture formation. Okay, we call it as trachealization of the esophagus. Because these strictures, if you look at them in the endoscopy, they look like they look like tracheal rings. Okay, although they are not truly tracheal rings, obviously, they are just strictures. There is damage to the esophagus. And when such a patient of EOE who has strictures in esophagus, when he eats any firm food, for example, beef, chicken nugget, okay, some big bolus which has firm consistency, okay, that big bolus will get stuck in these strictures and this will cause obstruction. Okay, in any case where the person cannot swallow their saliva, it means that the obstruction is complete. Okay, so saliva is unable to go down. So what do you need to do in such condition? Esophagoscopy. Just you have to diagnose and take it out. You have to do something which is diagnostic as well as therapeutic. Since such patients usually they present in the emergency department with food bolus impaction, so they usually go and esophagoscopy for the removal, and then we can take biopsy from these strictures as well from multiple sites and look for the diagnosis of EOE. If it is greater than 15 eosinophils per high power field, then it is a diagnosis of EOE. Okay. Other maneuvers, this Heimlich maneuver, this is for relieving the airway obstruction. For example, if the food or anything is stuck inside the airway, the trachea, then we do the Heimlich maneuver in order to relieve the choking of the patient. Okay, there is no role of food stuck in esophagus. Heimlich maneuver has no role. Ipecac syrup, it was used first before because it induces vomiting. So it used to relieve the obstruction, but it is not recommended anymore. Never choose this option. Barium swallow is for diagnosing certain esophageal conditions, but it is not recommended right now because the patient has presented in emergency department and he cannot swallow his saliva. Okay, so the most important here right now is esophagoscopy. So this is from Australian Prescriber. This is a very good article, tells all the conceptual things about EOE. And see, food bolus impaction, you need to have urgent upper GI endoscopy. This is another article of the same topic. And this is from Australian Therapeutic Guidelines. The important thing is here, this should be performed, this upper GI endoscopy should be performed urgently if the patient is unable to swallow their saliva. Okay, so this answers your question straight away. So the next question is, an 83-year-old lady with Colles fracture 3 days at hospital, catheterized on admission, UFR is less than 10, red cells less than 10, urine culture shows 10 raised to the power 5 bacteria. What is the most appropriate next management? Repeat MSU in culture, treat with trimethoprim, give IV antibiotics, do nothing and discharge. So this patient is a very elderly female. She was admitted to the hospital with Colles fracture. Okay, and she was there for 3 days. Urine culture they have done, it shows 10 raised to the power 5 bacteria. But this is asymptomatic bacteriuria. There is no urinary complaints, no dysuria, no decreased frequency, no burning micturition, nothing, no urinary complaint. Okay, so we do not treat asymptomatic bacteriuria in such patients. Answer would be do nothing and discharge. There are only two conditions where we treat asymptomatic bacteriuria. What are those conditions? One is pregnancy, yes. In pregnancy, you have to treat asymptomatic bacteriuria. And second condition is any endourological procedure which involves the endothelium of the urinary tract or genital tract. Okay, yes, one example is TERP, because in TERP, what you have to do, you have to slice the prostate gland. Okay, so there is an instrument which gradually slices the prostate gland. So you are in very much contact with the endothelium membrane of the mucosal membrane of the urinary tract or the genitourinary tract. Okay, so there is a high chance that you can introduce these bacteria into the bloodstream. You want to avoid this condition. Okay, so any procedure which would involve the mucosal exposure of the genitourinary system, only then we have to treat asymptomatic bacteriuria beforehand. The un, the procedures can include any procedure like TERP or any other endourological procedure. Okay, sometimes people confuse that it involves cholecystectomy as well because there is mucosal involvement or thing like that. No, only genitourinary mucosal involvement. Okay, because this bacteria is in urine. We don't want urine bacteria to go into the blood straight away. Okay, so pregnancy and endourological procedures, you have to treat bacteriuria, asymptomatic bacteriuria, only in these two conditions. Other than that, this lady, she was just here for Colles fracture, and now we have incidentally found asymptomatic bacteriuria. She doesn't have any urinary complaints, so we don't need to treat her. We can just discharge after her treating her Colles fracture. Okay, so this is from Australian therapeutic guidelines. Screening for and treatment of asymptomatic bacteriuria is not recommended except only two conditions: pregnant women, patient undergoing elective urological procedures. All right, just these two, just remember these two, nothing else. Tardive dyskinesia patient on haloperidol. What to do? Switch on quetiapine, reduce haloperidol. There is no option of stopping it. Benztropine, propranolol. So, propranolol, what is propranolol used for? Propranolol usually we use when there is akathisia. Okay, when there is restless legs. Okay, that is akathisia is also a side effect of typical antipsychotics, first generation antipsychotics, but it onset is within weeks. Tardive dyskinesia is something where there is involuntary movements of face like grimacing, protruding of the mouth, lip smacking, winking, and there is stiffness in the body. Okay, so all the dyskinesias, any abnormal movements of the body. And tardive itself, the word tardive means late onset. Okay, so any atypical movement, any abnormal movement of the body that is appearing late, that is within weeks to after months to years, that is called tardive dyskinesia, and unfortunately, it is an irreversible condition. Okay, even if you stop the haloperidol, this tardive dyskinesia won't go away. But of course, you don't want to keep it aggravating. So that is why you have to stop the haloperidol and you have to switch to atypical antipsychotic, that is second generation antipsychotic. So you will choose switch to quetiapine. Quetiapine is a second generation antipsychotic and it has a very less extrapyramidal symptoms. Okay, so now we say that how can we abruptly stop haloperidol? So obviously you're not going to abruptly stop it. So this is the baseline zero level, and this is the baseline level of the haloperidol in the patient. So you will gradually taper it. The levels will continuously fall in the blood until they reach zero. But what will happen in this, that for example, if this patient was taking for his schizophrenia, okay, so maybe his schizophrenia will come back if we just try to reduce the haloperidol. So what we will do, we will start the patient on quetiapine. Okay, so this is the zero level. At the time we are reducing the haloperidol, we are increasing quetiapine. Okay, so we will start quetiapine the moment we are going to reduce the haloperidol. Okay, so sort of we are switching to another drug. What is the goal? The goal is that at one specific time, the level of the antipsychotic should remain same in the blood so that the disease should not come back. Okay, by the time the haloperidol would reach to zero, the quetiapine would reach to maximum. Okay, so that is why the appropriate answer would be to switch to quetiapine. Reducing haloperidol does not say that we are starting another drug. Okay, so this is not an appropriate option here. Benztropine. Benztropine is used when there is some Parkinsonism, that is rigidity, cogwheel rigidity, any resting tremor, any shuffling gait, bradykinesia. Okay, the acute extrapyramidal symptoms. Then we can give the benztropine in order to stop that. Propranolol we give, like I said, for akathisias, which is a generalized restlessness in the body. It comes over weeks. It starts within weeks, and we can give propranolol for akathisia. But for tardive dyskinesia, it is an irreversible condition. We need to change the drug to second generation antipsychotic, and if quetiapine or any other second generation antipsychotic does not work, then we can start the patient on clozapine. Okay, clozapine is also a second generation antipsychotic, sorry, but it has a very serious side effect of agranulocytosis. You must be knowing from your emetics if you have solved. Okay, so this is just a last resort. If even quetiapine does not work, then we have to take the patient to the clozapine. Okay, so this is the sequence of how you carry with your antipsychotics. And all of this information is written very clearly in Australian therapeutic guidelines. Okay, so for this is the screenshot from therapeutic guidelines. Tardive dyskinesia. If it occurs, switch to another antipsychotic, changing from a first generation to a second generation, or specifically, if it doesn't work, then to clozapine. That is the best substantiated approach. Okay. Okay, so now we have a colleague who is taking marijuana between consultation and had recent marriage breakup. What to do? Tell medical board, talk to him first, or suggest him to have psychiatric consultation. So that is also a very controversial question, and it does come in exam. You need to make your concepts clear regarding it. I've taken these screenshots from EPRA. Okay, they have given a PDF properly. So when do we need to report to EPRA? Okay, so non-treating practitioner, we are just a colleague. We do not treat this patient for anything. So we are over here. Okay. So are you providing a health service to another practitioner? No, he's just your colleague. We're not providing anything to him. Okay, so do you have a reasonable belief that the this practitioner is intoxicated by alcohol or other drugs? Our scenario does not mention anything like that. It just says that he's taking marijuana between consultation, and it does not say that there is some symptoms or signs he's developing. Okay, so we have not made a reasonable belief that he's intoxicated right now. Okay, so there is no reasonable belief, no. Then there is no mandatory notification, but you can consider whether to make a voluntary notification. You can try talking to the colleague first. If he does not listen to you and if he still keeps on taking marijuana, then you will make a reasonable belief and make a mandatory notification. You will notify APRA after gathering enough information. Okay, so they have given two examples. While at a party over the weekend, you see a colleague with a group of people smoking marijuana. You wonder if this is also going on at work, as you have not formed a reasonable belief that your colleague is intoxicated at work. There is no need to make a mandatory notification. But second example, you see that your colleague is coming back from a long lunch and they smell of alcohol. Okay, so now there are signs and symptoms. There is smell coming, there is an unsteady gait, and there is slurred speech. So now you have directly seen with your own eyes, you have made a reasonable belief. Okay, so now you have to make a mandatory notification. So you have to look for in your scenario that what is the condition of your patient. They will be giving you some signs and symptoms. If they are present, then tell medical board directly. If they're not present, then you can try talking to him first. Okay, suggest him to have a psychiatric evaluation. That would also, when you try talking to him, you can, if there is some problem, you can try to refer him. Okay, you can just suggest him. So this is also, they have also given a definition of reasonable belief that gossips, they should not be gossips. Okay, you should be able to see by your own eyes. They should not be rumors, gossips. They're not enough to make a reasonable belief. They should not just be a suspicion. You need direct knowledge. Okay. Like I said, doctor, if they are smoking during non-working hours, as long as their work is not getting impacted, you cannot make a mandatory notification. I don't know about the legal or illegal thing, but patient care should never be compromised. So for this question, the best answer is try talking to him first because the recaller has not mentioned anything that the patient care is being compromised or there is some side effects of marijuana, some symptoms of marijuana appearing. Recaller has not mentioned anything like this. So for now, we can go with try talking to him first option. But if the recaller had mentioned anything like he's having euphoria or anything, then definitely we would tell APRA. So it's sort of an incomplete recall, I would say. Okay, just two questions are left, doctors. Question on man who started working in a horse stable and had wheeze. How to test spirometry with bronchodilator trial or allergy testing? So this is this is occupational asthma. Okay, he has started working in a horse stable and now he has developed wheeze. So in order to diagnose any type of asthma, you have to do spirometry. Okay, and you can give him a bronchodilator trial. This is from the Australian Asthma Handbook. This is for referring to any asthma questions. So first you see that whether there are respiratory symptoms present which suggest asthma. What are the respiratory symptoms? There can be wheeze, there can be shortness of breath, chest tightness, or coughing. Okay, or symptoms are they present seasonally, they are worse at night or early in the morning. There is history of any atopy, allergic rhinitis history. Okay, there are some known triggers present, right? Any of these things are present, we are suspecting asthma. So what do we have to do? History and physical examination findings, whatever I've just stated, all that things, it is showing that the patient has asthma, then we have to do spirometry. Once we do spirometry, okay, then we give the patient a bronchodilator, okay, which is a SABA, short-acting beta agonist. And then we look at whether the reversibility is there or not. FEV1 has whether it has increased greater than 200 ml or greater than 12% from the baseline. If it is improved, it means it is a reversible condition, which is asthma. Okay, so bronchodilator trial is necessary to differentiate between COPD and asthma. And if there is reversibility present, yes, then it is asthma, then we will start asthma treatment. Okay, so in our patient, we need to see first that whether this wheeze is due to asthma or not. So we will do spirometry, then bronchodilator trial and spirometry again to look at the reversibility. Allergy testing, we can do that what type of allergens he is allergic to. For example, any dust or pollen or anything from the horse stable that would be known by the allergy testing. But allergy testing does not, you know, make any change in our treatment. If this patient is having wheeze and he needs any SABA or things like that, any inhaler, so we need to first know that whether he is having asthma or not. So spirometry is a better option in order to test. After that, when he's prescribed, we have prescribed him everything. After that, we want to know that what type of allergen he is allergic to. So we can refer him for allergy testing to an allergy specialist who will tell that, okay, you are allergic to these allergens, just try to avoid these. So that will be as a next step, not the immediate next step. That would be in the further steps. So I have attached the reference of the asthma handbook. Last question of the day, guys. Aspergilloma CT is given. So now this question has come with the CT scan. So make sure that you look at the CT of the aspergilloma. They are asking for the most appropriate next investigation, sputum culture or percutaneous biopsy. So since CT scan is already given, so this is a most obvious thing that they must have done the sputum culture already. Okay, and aspergillus is very commonly present in the environment. It is a fungus, but since we are immunocompetent, so it doesn't affect us. It only affects the people who are immunocompromised. Or for example, if a patient had TB, and now there is a cavitary lesion inside that lung. The TB has resolved, but there is a cavitary lesion. So the patient is immunocompromised. The aspergillus would come from his upper airway, his throat, and it would just reside in this cavity, and it would make a fungal ball here. Okay, and this is a crescent sign we would see on the chest X-ray or the CT scan. So this aspergilloma, okay, they have been discussed previously. So this is the crescent sign, aspergilloma. So we can do the chest X-ray, then we can do the CT scan. When we have done the CT scan, there is no role of sputum culture. Okay, so we can do the percutaneous biopsy, but these are only two options. In another option, for example, if you have any bronchoalveolar lavage or biopsy on the bronchoalveolar tissue sample, that would be the better option. Okay, because percutaneous biopsy is also done, but that is done on the peripheral lesions. So depending also on the location where CT scan on the CT scan where the lesion is present. Okay, so this is how it looks like. This is a air crescent sign on CT. This is the aspergilloma. And why do we need to do the biopsy, guys? Because aspergilloma is sometimes it is asymptomatic, but in immunocompromised people, it can cause invasive aspergillosis. Then that would be a very dangerous disease. So we need to differentiate whether it is invasive disease or not. That is why we do biopsy. So this is the different view of the CT scan, and this is the aspergilloma here. So if you have the option of bronchoscopy or bronchoalveolar lavage, that would be the better option as compared to the percutaneous biopsy. I've attached references as well. Thank you so much, guys. I hope you learned something from me today. I have attached all the things from Australian guidelines mostly, and it is very easy if you just if you just get the idea that how you have to study, then it would be easier for you to study for this exam. And maybe there are many of you who have given a few attempts before. So if I have told you something different from your approach, try to follow this. You'll be able to clear the exam. Thank you, doctor. About subscription, yes, Dr. Arshan will be better person to ask because I don't handle those things. So thank you everybody and good night.